Hey everyone, this is Derek with Orthopedic Physical Therapy Products. And thank you so much for joining us today for this Next Level episode in collaboration with EIM Evidence in Motion. Now, this content series, Next Level, is of course meant to inform and inspire all the clinicians out there who are looking to take their quality of patient care and knowledge to the next level. Today, we're joined by Emilio Puentedura of EIM. Louis, thanks for so much for joining us today. And today the
Yeah,
topic is
sure.
going to be, today we're going to talk about pain science, right? Which is a really hot topic right now in the clinical world. And I'm excited to go through some of these questions with you and kind of learn and get inspired myself. So will you just do a quick intro for us, for those of you who aren't familiar with you and your work?
Oh, sure. My name is Louis Puentedura. Actually, it's Emilio Puentedura, but I use Louis as my nickname. And I graduated as PT way back in 1980 in Australia. Hope I still have a little bit of an Australian accent. Whenever I go home, they say I sound very American. I came here in 1995 and got my post-professional doctorate in PT and then a PhD from Nova Southeastern University. And got into teaching, postgraduate, education, mainly manual therapy and pain science.
Hmm?
And
Yep.
now I'm a professor at Baylor University.
Perfect. Yep. Yeah, I've had the privilege of talking to you quite a few times about pain science and interviewed you about some of your books and stuff like that. For those of you who aren't
Hmm.
familiar, Louis is a established author as well, has contributed to a number of publications that we carry, mostly under the pain science umbrella or manual therapy, of course.
Hmm.
But yeah, well, let's go ahead and get this kicked off here with our first question, which is one that we find always interests people, regardless of the interview they're watching in this next level content series. But will you share with us the most profound story where you observed, in this case, pain science, your practice helping a patient or student make progress or make a big impact in their lives?
Sure. I think the one that really stands out to me is one that I actually treated before I knew much about pain science. And it just sort of, it happened. And it was only once I learned about pain science that I looked back on it and I thought, oh my gosh, that's why it helped. I had this patient. He was a Mexican national. This is when I was living and working in Yuma, Arizona, right on the border with Mexico in Sonora. And he was a foreman for a citrus growing company. And he got his foot caught in a conveyor belt and totally mashed his foot. When I saw him, he couldn't weight bear on this foot, and it looked like a football. It had big gashes in it, still open wounds, and there was no way that he would let anyone touch his foot. And I had to be creative in getting him to weight bear and start to think that his foot would function normally if he just started using it. And without really understanding what I was doing and without that knowledge of pain science, I realized that I followed the pain science approach because explained to him that pain he was feeling was normal and it would go away if he understood what was going on. He had lots of misconceptions about, what the pain in his foot meant and what it meant for his recovery. And so it was that sort of gentle approach and developing a great therapeutic relationship with him that really helped. And the turning point for him that really helped me get him to start weight bearing and start using his foot, and that really sped up his recovery, was a very innocent little question that he had for me. It's just kind of funny, but he asked me about when it would be safe for him to have, relationships with his wife. And I thought, that's an odd question to ask. I said, why do you ask that? And he thought, well, my wife tells me that if we do, that it's bad for my foot because it draws the blood and the circulation from the foot. That would be a bad thing. So I shouldn't be doing it. I just smiled at him and I said, I think your wife is just, having you on here. There's no reason why you can't, have a normal relationship with her. In fact, it will probably be very healthy. And the next visit when he came along, he had a big smile on his face. He was happy. He started weight bearing, and his wife was glum. She was very mad at me because I had upset the relationship a little bit. It was so funny. It was just getting back to life.
Yeah.
And I always look back on that and think, wow, I guess I started doing some of the things that we learned about pain science without really knowing it, just by listening to the patient. So that was profound for me.
Yeah. I hear a lot of the same thing about people who've taken either your courses, EIM courses, or read some of the books that it's almost a natural response they've had, and they've learned that that response is part of pain science. You know,
Hmm.
natural
Yeah.
caring human response to pain and caring. So
Yeah.
that's great. Well, let's back up even a little bit more to and this is the next question is, what initially inspired or led you to specialize or focus in pain science?
That's quite a long story, but I'll try and shorten it as much as I can. When I graduated from PT school, I did not think I was going to get into orthopedics at all. I really didn't like orthopedics. I was more of interested in the neurological rehabilitation, because I grew up with a sister who was affected by polio, and she had lots of friends that had, neurological disabilities. But once I did get involved in orthopedics and realized that it was, I could really have a profound effect on people with musculoskeletal injuries, that's when I got really interested into the manual therapy. And I had lots of Maitland training, and I worked with some pretty big names in manual therapy. But in clinical practice, I noticed that there were patients who tended to get better, and I realize now that they were nociceptive dominant patients. Their pain was very straightforward, and it was the ones who had more nociplastic pain or central sensitization that just wouldn't get better, and we couldn't help them with the manual therapy. So that's what got me into thinking about there's a neurological aspect that we're not looking at. And so I got heavily involved in neurodynamics, or mobilization of the nervous system, or adverse neural tension. In fact, I did my dissertation in 1983 on the effect of spinal posture on the straight leg raise. So that sort of sparked the idea that manual therapy is more than just joints, ligaments, and muscles, that there are nerves involved, and they need to move, they need space, movement, and blood. And then at that point, I thought, wow, this is good. But there was still some patients that weren't getting better, even though we had the manual therapy plus the neurological component to it. And that's when, the psychological component came into it. And that's when, we suddenly realized, oh, there's a brain attached to these nerves. These nerves are sending messages to a brain, and the brain has a consciousness, but it also a brain does things for us, without us thinking about them. And that is the thing that opened up, and I thought, oh, wow, I heard Louis Gifford speak once, and that just blew my mind. And I thought, wow, this is amazing. And ever since then, of course, it's just been progress and progress and progress from 2002 to now, 22 years of progress on pain science.
Uh-huh. That's a great segue into the next question too. I guess over the last 22 years, how has integrating this knowledge helped you take your career and patient care to the next level? I think you started to
Mhm.
explain that already, but yeah.
Yes, yeah. I think, being a manual therapist, and especially a manipulative therapist, I'm not shy about manipulating the spine, including the cervical spine. I learned lots of osteopathic techniques, and the early part of my career was a focus on, becoming really good with my hands, and really good in the techniques. And I had successes. I think they were mainly nociceptive dominant pains. And I had some successes with peripheral neurogenic type pains as well. But it was touch and go with those patients that were more the nociplastic pain, the patients that needed a little bit more pain science. And what it did, learning about pain science and integrating that knowledge into my manual therapy, changed the way that I did the manual therapy. I
Mhm.
became a lot more focused on how the patient was interpreting what I was doing. So I wasn't so focused on whether am I doing this the right way? Am I moving the joint in the right direction with the right amount of force? Is it comfortable? That's what had been the focus before. And now it became more of a focus of what is the patient experiencing?
Mhm.
How do you feel when this is happening?
Yeah.
And what it's done is made me much, much gentler. And the big profound thing, the difference that I've noticed is that in the past, years ago, patients would get better, but they would tell me when they came back to visit after a treatment that they had some post-treatment soreness. And I would tell them that's okay, as long as it's gone within 24 to 48 hours, that's fine. It's just a little side effect of the manual therapy, not a big deal as long as it goes away. But once I incorporated some of the pain science knowledge and I changed the way that I performed my manual therapy, suddenly, patients were coming back and they had no post-treatment soreness. And when I asked about it, they would say, no, I felt great. Was I meant to feel sore afterwards? No, I guess not. That's right. And I think it's because of the melding of the pain science with the manual therapy.
Hmm. I'm going to go a little bit off topic here, but one talk that you gave for OPTP actually on Pro Talks was about manual therapy techniques and how just good techniques, just being good at it isn't good enough. And
Yes.
you spoke to how incorporating pain science into it can make you that much better. And that's always stuck out to me. And I've actually had people at trade shows and stuff come up and tell me that they remember that topic from you because it impacted their quality of patient care so much, and that's
Yeah.
exactly what you're referring to here. So yeah,
Hmm.
that's awesome. Well, let's move on to the next question. You've already started to answer this one too, but why should someone else, either a current clinician or up and coming, say PTA or a student, why should someone else consider adding pain science education into their clinician toolbox?
Well, I think for me personally, what it did was prevent burnout. I think that one of the reasons that I came over here to the United States and I left Australia is because I was going through a bit of burnout. I was doing manual therapy, but I was working in a clinic where, volume of patients was more important than the quality of care. And so I felt like I really wasn't a very effective PT. And I felt like, I just wasn't good at what I was doing. And I felt like it was more work rather than joy and a passion. And so I had this idea that coming to the States, I'd learn more about exercise and I'd incorporate manual therapy plus exercise and have better results. And when I came over here, yes, that's what happened. It definitely made a big difference. I had a renewed passion because I could spend more time with patients. I could, focus on their care and make sure that I was doing what was appropriate for them. And the new pain science stuff started to come in as well. And now I felt like I had an extra tool so that I wouldn't have these patients that I would have to say to them, look, we've tried all these different things and it's just not working. I guess you're just mechanically a non-responder. There's nothing I can do to help you. It was disastrous, doing that kind of a approach. So having that as an extra toolbox, not only does it help you help patients that need that kind of intervention, but it opens up a brand new world for you. It opens up a new area that is exciting because when you can help someone that really needs it and has been struggling for such a long time, it's such a good feeling and it makes you glad that you're doing what you're doing. It makes you want to get out of bed and go to work and see patients every day.
Yeah, that's a yeah, great answer. So
Thanks.
hopefully we've built a case now for pain science, why it's important to level up with this type of knowledge. Describe
Mhm.
to us what it's like to partake in an EIM faculty-led course on pain science. What's the experience?
Yeah, I enjoy them. I tend to teach mainly the manual therapy for the nervous system course, the neurodynamics. I'd love to teach more of the pain science courses, but we've got other faculty who are just spectacular at doing that and great at motor imagery. And I love doing the manual therapy of the nervous system courses because it helps me bring in the manual therapy part with the pain science. And I really view myself as a pain science manual therapist rather than a pain scientist or just pain science. So I love going to those courses. Usually they're very big. They have 20 to 30 people. So I always have a teaching assistant come with me, and the faculty that join me to co-teach are super exciting. It's always fun to have more than one person teaching a course. A larger group makes it much more fun. And I think the thing that really excites me is seeing how at the start of the course, all the course participants are eager to find out what's going on. What am I doing with this? And when they start to practice some of the techniques, they look like, they're not really sure how to do it. What's the sequence of doing this? And how am I doing this right? And they're just not very good with their hands and with their position and their posture doing the techniques. But by the end of the course, they are just killing it. They look confident, they do it well. And one of the things I like to do is at the end of a course is get all the course participants to actually teach everyone the techniques. And as they stand up on the stage and demonstrate the techniques, it's just wonderful to see the confidence that they have. I really get the sense that they're going to go out on Monday and start to use those interventions, the manual therapy techniques for the nervous system that they've learnt over the weekend. But not only that, they're going to teach it to the other faculty, the other staff PTs that they have in their clinic. And it's that sort of excitement, I hope, that they take into the clinic after a weekend intensive that makes a difference. And getting emails from course participants telling me that they've seen a patient, they've tried some of these techniques and it's working and they love it. That's always a big thing as well.
Yeah, I'm sure that's very rewarding. Excellent.
Hmm. Yeah.
Well, um, we'll move on to the next question here with all your experience in the PT space and not only direct patient care but also in education. What's one key piece of advice you give to a current clinician or an up and coming student who's interested
Hmm.
in working under the PT, OT, even DC umbrellas? What's one key piece of information you give them?
Well, I think you've just got to keep looking for that spark, that passion that you have. I teach at Baylor in an entry-level DPT program, and we often have students that are coming through the program because it's a hybrid model. They tend to be students that are doing it as a second career. Um, about half of them come straight out of undergraduate, but there are others that have already been PTAs or they've been sports therapists, massage therapists, those kinds of things. And they've got this passion for becoming a PT. And they usually come in with an idea of what area of PT they want to specialize in, be it geriatrics, neurological, musculoskeletal, pediatrics. And I always tell those students that stay open. Leave yourself open to experience everything. Don't come in, with a blinkered view and say, I want to be a sports therapist, or I want to be a manual therapist. I want to be a cardiopulmonary therapist. And then, sort of not have any interest in all the other things that you're going to learn, because there will be some other things that will just suddenly click with you. And when they do, that's when it can be super exciting. There are different areas of PT that strike the enthusiasm in patients, in therapists, and you've got to find the one that really speaks to you, the one that makes you want to read up a bit more, makes you want to do that research, makes you want to search for those courses so that you can improve your hand skills, so that you can interact with other therapists and see how they're doing the techniques and how you can change. And it's all going to lead to you having better results with your patients. And when you are actually helping patients, which is what all of us want to do, that's the thing that sort of keeps us excited and wanting to continue on as a PT. There aren't too many PTs who can say that they're still researching, they're still studying, they're still wanting to learn 44 years after graduating. And that's me.
Yeah.
I've been out for 44 years and I'm still super interested in reading, textbooks and researching different areas of PT treatment, reading up on knowledge, going to conferences, presenting at conferences. And I think that's what keeps me going. That's what keeps me energized. The fact that, I'm doing this not only to help the patients I see, because I still see patients on a pro bono basis, but also to help other therapists help their patients
Mhm.
and keep the profession growing and keep the profession expanding.
Yeah. I think you just kind of put together a really nice roadmap there to avoid burnout, right? Is
Oh, sure. Yeah,
stay open-minded until you find what you truly love and then keep taking it to the next level. Right?
that's right. Yep.
That's awesome. Cool. Well, we're gonna finish up right there, Lou. I think you gave us some really great advice. Really appreciate your time again. I'll just ask you, is there anything else that you want to leave people with before we sign off here? Well, let me mention real quick, if anyone does want to learn more about pain science, about Louis or any of the work done through AIM, you could just go on their website, right? It's very easy to navigate the site and find what topic or subject matter of interest you're looking for, including pain science. But is there anything you want to finish off with today, Louis, before we sign off?
Yeah, sure. You mentioned that talk I gave about being a manual therapist is being an okay therapist, just okay. And the reason I came up with that presentation was primarily because there was this theme going through social media that manual therapy, wasn't that effective, that it was a low value intervention, and that perhaps we should, just ditch it and not do manual therapy anymore. And I felt that's silly because manual therapy is a valuable approach. If you if you really have a passion for it and want to learn it, it takes some skill to do it well. And I thought, wow, there are people who are really passionate about blood flow restriction, and they're really good at blood flow restrictions. So they get great results. But if you're not good at it and you try it, you might think, blood flow restriction doesn't work. Same thing with dry needling. There are some therapists that just, love doing dry needling, and they're super skilled at where they put the needles in. The patients find that they have no discomfort. They get their treatments and feel immediately better because of the way they've delivered the dry needling, because they've had a passion for the dry needling. It wasn't just okay. It was more than okay the way they did that. And so I felt the same thing could be applied to manual therapy. Actually, the same thing is applied to everything that we do as physical therapists. If you don't do it with passion, with equipoise, I guess, with the belief that you are really going to help the patient. If you're doing it half-heartedly, then it's not going to work, and you're not going to enjoy doing it. And if that's the case, that's not the area of PT for you. Find the one that is. And it may be lifting, it may be powerlifting, it may be exercising, it may be progressing exercises. Wonderful. Become really good at that. And that's your passion. But don't speak ill of all the other things, because there's plenty of room for us to do all the different kinds of things that patients need.
Yeah.
And there is a subset of patients that really need great manual therapy.
All great advice. I really hope this helps a lot of our existing clinicians and up and coming clinicians. It's a wealth of great information in a short period of time here. So, well, thank you again, Louis, for joining us today. I will mention
Thank you.
also, just for those interested, if you want to learn more about Louis, or specifically check out some of the publications that he's developed, go to optp.com. We've got several of them on there, including some under the manual PT umbrella, some under pain neuroscience. So great style of education delivery, written as well as verbal, obviously here. So definitely check all that out. But Louis, thank you again so much for joining us today. Thank you everyone for checking out this interview, and we'll see you next month on our next episode of Next Level. Thanks. We'll
Thank
talk.
you.